How to distinguish deadly versus common bowel issues. Let's talk first about what gas is. Gas is produced in both the stomach from swallowed air and the intestines, primarily the large intestine, colon, where gut bacteria ferment undigested carbohydrates, creating gases like hydrogen, carbon dioxide, and methane. While the stomach contributes solid air, nitrogen, oxygen, the main source of smelly significant gas comes from bacterial fermentation in the large intestine. Flatulence, commonly referred to as farting, is caused by gas in the bowel. The intestine produces between 500 and 2000 mL of gas daily, which is passed out of the anus at regular intervals. The gas, or flatus, consists of a number of gases including methane, nitrogen, and carbon dioxide. The varying smells depends on the ratio of gases, which is influenced by foods we eat. Flatus is generated by solid air, we said that, digestion, high-fiber foods, and byproducts of intestinal bacteria. Some digestive system disorders, such as irritable bowel syndrome, can cause excessive gas production. In this video, I will explain how intestinal disorders affect patients and provide guidance on caring for them with those conditions. The most common intestinal disorders are bowel intestinal obstruction, hernias, hemorrhoids, inflammatory bowel disease, irritable bowel syndrome, celiac disease, diverticulitis, appendicitis, colorectal cancer, abdominal trauma. This is the chapter 58, Coordinating Care for Patients with Intestinal Disorders from Davis Advantage Medical Surgical for Nursing. The learning outcome for these all 10 disorders is going to be covered in this video, and I will describe the epidemiology of infectious and non-infectious intestinal disorders, correlating clinical manifestation with the pathophysiological processes. The diagnostic results are used to confirm the diagnosis of selected intestinal disorders, their associated complication, and the nursing management. Please use the chapter's timestamp to guide you to the specific disorders that you are interested to learn more. This is my concept map. This I use before I get into the diseases. I like to see like a map how the chapter gets simplified. I hope you like this style and join me to the end of this video. Med-Surg chapters are about 50 pages long, and half of the time you can tell what is important. Before we get into the details, I would like to zoom out first to look at the big picture of the chapter. I use a concept map like these to break it down heavy chapters. As I mentioned, I will have it something different. I'm using the Xmind to make this beautiful concept map. So this is my concept map for chapter 58, Coordinating Care for Patients with Intestinal Disorders. We have introduction and all these 10 disorders. And here are what we're going through. So first, since we are starting with introduction, I'm gonna move a little bit. So introduction, the intestinal system. We have the small intestine, large intestine, vermiform appendix. So the small intestine, we have the function, it's digestion and nutrient absorption. The section, it's duodenum, jejunum, and ileum. The length, it's approximately 20 feet, so it's about 6 meters. So here, and duodenum, it attaches to pylorus, so it's about 25 centimeters. Jejunum, it's approximately 8 feet, 2.5 meters. Ileum, it's approximately 12 feet, 3.5 meter. The large intestine, we have function, water and electrolytes absorption, feces formation, waste storage. The section, it's cecum, colon, which is ascending, transverse, and descending, sigmoid, and then the rectum. The length is about 5 to 6 feet, which is like 1.5, close to 2 meters. The cecum, it's approximately 5 to 8 centimeters. Colon, it's ascending. The right side extend upward, transverse, horizontal across abdomen, descending left side extend downwards. Sigmoid, it's the lower S-shaped curve. Here we have the rectum, which is approximately 17 to 20 centimeters extend to anus. We have the vermiform appendix located behind cecum, approximately 8 to 10 centimeters, accessory organ with no known function. So this is the introduction. We've been covered for this chapter. Now I need to make a little bit, you can short screen for the introduction. Bowel obstruction, the intestinal traffic jam, and here are the key terms that we covered in previous video, so you can see in this image where are they. Bowel intestinal obstruction, epidemiology, blockage of the normal flow of contents through the small or large intestine. Prevalence increases with age. We have small bowel obstruction. The causes, it's often a complication of surgery. Often causes it's hernia, volvulus into suspension, gallstones, small bowel tumor. The large bowel obstruction, about 20% of intestinal obstruction occurs, causes malignancy, volvulus, incarcerated hernia, adhesions, strictures, diverticular disease, begin polyps into infection typically require surgery. The pathophysiology, we have a small bowel obstruction, usually associated with adhesions, bands of connective tissue. Adhesions bond section of the intestine obstructing flow. Increased peristalsis and mucus accumulate worsen the blockage. For the large bowel obstruction, it can be partial or complete. Classified as mechanical, which is physical blockage, or neurogenic, non-mechanical, often from surgery or irritation. Mechanical causes adhesions, strangulated hernia, stricturous tumors, impaction. Can be a complication of diverticulitis or colorectal cancer. For clinical manifestation, small bowel obstruction, it's abdominal distension, sharp cramping, intermittent pain from hyperactive peristalsis. Continuous severe pain may indicate strangulation, which is a medical emergency. Nausea and vomiting leading to fluid electrolytes imbalances. Diarrhea with incomplete obstruction. For large bowel, its complete inability to pass gas or have a bowel movement, continue abdominal pain, distension, tenderness, rigidity, no bowel sound. When it's partial, gas and bowel elimination may occur, but with abdominal pain and distension, high-pitched bowel sounds. For interprofessional management, we have medical management, diagnosis here, abdominal X-ray, CT scan, or MRI. Colonoscopy for large bowel obstruction if X-ray are inconclusive. For the treatment, initial step, it's NG tube for decompression, IV therapy for fluid electrolyte replacement, including potassium. For small bowel obstruction, often resolved with medical treatment, pain meds, antiemetics, antibiotics. Dexamethasone may be used to treat inflammation. Laboratory tests, CBC, especially white blood cells count, and serum electrolytes boom. For surgical management, it's required for complex obstruction. Procedures include laparoscopic approach for adhesions, surgical removal of dysfunctional area, anastomosis, or exploratory laparotomy with colectomy and creation of a temporary or permanent colonostomy. Complications: intestinal perforation, bacteremia, sepsis, abscesses, pneumonia with aspiration, dehydration, electrolyte imbalances, acid-base disturbances. Untreated complex obstruction can be fatal within hours due to shock. For nursing management, we have assessment. Clinical signs may vary based on complex or incomplete obstruction. Symptoms include pain, nausea, vomiting, decreased blood pressure, decreased or absent bowel sounds, and changes in defecation. Nursing diagnostic, we have acute pain related to abdominal distension, fluid volume deficit related to vomiting, diarrhea, NG suction, hypokalemia related to fluid loss. Nursing intervention, assessment vital signs, INOs, bowel sounds, serum electrolytes, white blood cell count, pain level, NG tube placement, patency. Key patient NPO, administer IV fluids and antiemetics, provide NG tube and oral care. Position patient with head elevated, prepare for surgery as indicated. Teaching, preoperative and postoperative teaching, including turning, coughing, deep breathing, ambulation, and ostomy care as needed. Evaluating care outcomes depends on the severity of obstruction and whatever surgery was required. Discharge criteria, resolution of obstruction, tolerating diet, and for surgical patient, tolerating diet, having bowel movements, and being comfortable with ostomy care. So for you to have a nice here is a flashcard that might help you when you prepare for your exam. Hernias, the abdominal bulge, we have many types and we go one by one now. Hernias, we start with epidemiology. The definition is a protrusion of abdominal contents through a wicked area of a muscle. Can be congenital or accurate. The risk factor: obesity, smoke, excessive wound tension, malnutrition, pregnancy, immunosuppressive agents, and aging. Growing hernias, inguinal and femoral. Inguinal hernias are more common in men. Femoral hernias are more common in females. We have the ventral versus incisional hernias occurs at the previous surgical site, often due to infection or poor wound healing. We continue with pathophysiology. Occurs when intestine protrude through an abnormal opening. Reducible contents can be easily pushed back into the abdominal cavity. Irreducible, incarcerated contents cannot be pushed back. Strangulated, an incarcerated hernia where the blood supply is obstructed, causing a medical emergency with symptoms of intestinal obstruction. Causes: straining, urination, bowel movements, lifting heavy objects, muscle strain, weight gain, chronic cough, and weakened abdominal muscle from previous surgery or aging. We go to types of hernias. We have inguinal, approximately 96% of groin hernias protrude through the inguinal canal. Indirect inguinal congenital occurs when the inguinal ring doesn't close properly after birth. Direct inguinal acquired in adulthood due to connective tissue degeneration and weakened muscle. Femoral, 2 to 4% more of growing hernias, more common in women. Often present as incarcerated or strangulated and are medical emergency, occur below the inguinal ligament. Umbilical, located at the umbilical ring, more common in women, associated with increased abdominal pressure, obesity, pregnancy, can be congenital, may close on their own in infancy. Ventral, its primary ventral, includes epigastric midline between umbilicus and xiphoid process and umbilical. Incisional forms at previous surgical site. Incision site, highest incidence with midline abdominal wounds. We go to clinical manifestation. We have typical presentation, a bulge or visible swelling, often with coughing or straining, an ache that radiates to the area, strangulation, incarceration, abdominal distension, nausea, vomiting, pain, fever, and tachycardia. This is a medical emergency. Interprofessional management. We have the diagnosis. Primary by physical examination can be confirmed with hernianography, ultrasound, CT, or MRI. Non-surgical management for poor surgical candidates, a truss or binder can be used to hold the hernia in place. For surgical management, we have the herniorrhaphy, the surgical procedure to repair a hernia. Then we have hernioplasty, a hernia repair using a synthetic or biological mesh to reinforce the area and prevent reoccurrence. Can be performed via laparoscopy, short recovery, or open laparotomy. Strangulated hernias require excessive surgery. Post-operative care, it's when patients should not be encouraged to cough. They should splint the surgical area if they must. We have complications. Strangulation. It impedes intestinal flow and blood supply, leading to intestinal obstruction or tissue necrosis. May require a bowel resection. Surgical complications. There are nausea, vomiting, urinary retention, sore throat, and headache. Post-operative pneumonia and VTE prevention can be prevented with early ambulation and deep breathing with splinting. Recurrence, the hernia can reappear, requiring another surgery. For nursing management, we have the assessment. Clinical manifestation vary by location and type. Assess for bulging, swelling, pain, feelings for fullness. In a strangulated hernia, assess for painful engorgement, nausea, vomiting, and abdominal distension. The nursing diagnosis is acute pain, knowledge deficit, and risk for infection. Nursing intervention, assessment, vital signs, of course, pain, in a nose and surgical site. Encourage deep breathing and early ambulation. Administer pain medication, apply ice pack, and elevate scrotum for inguinal hernias. Begin with clear liquids and advanced diet as tolerated. Teaching discourage coughing, teach splitting instead. Avoid heavy lifting for several weeks and teach pain management and signs of infection. The evaluating care outcome return to previous function in 6 to 8 weeks. Outcomes include stable vitals, absence of infection, and normal bladder bowel function. For poor surgical candidates, outcomes focus on comfort and understanding the signs of strangulation. Hemorrhoids, the swollen vein in the anus area. The hemorrhoids, the epidemiology definition is swollen or dilated veins in the anorectal area, also known as varicose veins of the rectum. Causes its straining during defecation, chronic constipation, heavy lifting, and prolonged standing, sitting, obesity, pregnancy, portal hypertension, increase in intra-abdominal pressure, heart failure. Prevalent is common disorder affecting 20 to 39% of the population, more frequently reported by females. And we go to pathophysiology. We go with types. Internal, so it's lie above the dentate line in the anal canal, not visible on visual inspection. We have external, lie below the dentate line, visible. The next type is prolapsed, protrude through the anal canal, strangulated, prolapsed hemorrhoid trapped by the anal sphincter, compromising blood flow. Thrombosed hemorrhoid with a blood clot. Grading system for internal hemorrhoids are grade 1, bulge into the lumen but not prolapse. Grade 2, it's prolapse on defecation but reduced spontaneously. Grade 3, prolapse on defecation and must be reduced manually. Grade 4, prolapse and cannot be reduced manually, risk for strangulation. Clinical manifestation, we have asymptomatic. Approximately 40% of cases have no symptoms. Bleeding, almost always painless. Usually associated with internal hemorrhoids. External symptoms, itching, irritation, and pain in the rectal area. Prolapse may be visible protruding from the rectum, sometimes returning spontaneously. Pain can range from mild to severe. For interprofessional management, we have the diagnosis, visual inspection for external hemorrhoids, digital exam, anoscopy, and sigmoidoscopy for internal. The treatment, we have conservative therapy is the first line of the treatment. Symptoms relief, cold packs, sitz bath, adequate fluid and fiber intake, and stool softeners. Topical medication, it's nitroglycerin ointment for pain and various over-the-counter creams, suppositors, anesthetics, protectants, astringents, corticosteroids. We have for surgical management indication, seldom required for external hemorrhoids unless thrombosed, necessary for grade 3 and 4 internal hemorrhoids. Procedures, rubber band ligation, a band constricts circulation, causing the hemorrhoid to slug off. Bipolar, infrared, and laser coagulation. Uses heat or light to cause necrosis. Sclerotherapy, injecting a sclerosing agent to cause scarring and vessel disintegration. Cryosurgery, freezing the liquid nitrogen associated with intense pain. Hemorrhoidectomy, surgical incision of the vein can be left open or sutured. We have complication, post-surgical infection, pain, urinary retention, fecal implication, damage to the sphincter, bleeding, and abscess formation. Urinary retention can occur due to rectal spasms and pain. Fecal infection, a result of inadequate pain management and fear of having a bowel movement. Nursing management, assessment, it's assess the rectal pain, itching, bleeding, and inflammation. Post-operatively assess the reddening, swelling, and drainage. Monitor bowel movements to prevent constipation. Nursing diagnostics, we have acute pain, knowledge deficit, risk for altered bowel elimination, constipation. Nursing intervention, it's vital signs, fever, increased heart rate, visual inspection of the rectal area, bowel movement, frequency, character, pain, and intake output. The action, administer pain meds, especially before the first bowel movement, provide cold packs and sitz bath, administer laxative as prescribed, apply local moist heat after immediate postoperative period. The teaching, post-surgical site care, gentle washing and patting dry, preventing constipation, increase fluids and fiber, use stool softener, avoid narcotic analgesics, lifestyle, avoid straining and prolonged sitting, pain management, non-pharmacological method, and proper use of prescribed medication. Warning signs, contact a healthcare provider if unable to urinate or if signs of infection appear, like fever, chills, redness, swelling, drainage. Evaluating care outcome, patient return to normal function within a few weeks. Outcomes include stable vital signs, no infection, and normal bladder bowel function. For outpatient surgery, the patient and family must understand normal versus abnormal recovery signs. So that was a little summary of hemorrhoids. Inflammatory bowel disease, where has Crohn's disease anywhere in the GI tract, and ulcerative colitis, colon and rectum only. Chronic inflammation from active immune response. Irritable bowel disease, it's a little bit quite long. As you see, it's like a few pages. So the overview is inflammatory bowel disease, IBD, is a chronic inflammatory disorders of a gastrointestinal tract. Includes two type condition, the Crohn disease and ulcerative colitis. Characterized by periods of remission and exacerbation. No medical cure. Management focus on controlling inflammation and symptoms. The epidemiology, higher incidence in United States, Canada, United Kingdom, Sweden, Norway, high risk in some Ashkenazi Jewish population, American Jewish of European descent, age of onset, primary peak between 15 to 30 years old, secondary peak 50 to 80 years old. Historically, higher in white population, incidence increasing in black population. The pathophysiology, we have exact cause unknown, contributing factor, genetic predisposition, environmental triggers, immune system dysregulation, the mechanism, inappropriate immune response to normal gut bacteria, chronic intestinal inflammation, triggers infection, medication, cigarette smoking, stress, consequences, impaired nutrient absorption, diarrhea, weight loss, malnutrition, dietary associations, cow milk hypersensitivity in infancy, high refined sugar intake for Crohn's. Dietary fiber may reduce Crohn risk, but not the ulcerative colitis. We have clinical manifestation, the general gastrointestinal manifestation, it's persistent diarrhea, abdominal pain and cramping, blood from rectum, weight loss, malnutrition, fluid and electrolytes imbalances, mouth ulcers, systemic manifestation. We have fever, fatigue, anemia, delayed growth for pediatrics. For extra-intestinal manifestation, it's uveitis, sclerosing cholangitis, nephrolithiasis, cholelithiasis, joint disorders, skin disorders, oral ulceration. We go now for the Crohn's. Pathologic characteristic can affect entire GI tract, mouth to anus. Most common site is transmural inflammation, all bowel layers. Skip lesion with normal bowel between affected areas. Cobblestone mucosa. Clinical manifestation, we have the right lower quadrant abdominal pain, chronic diarrhea, usually non-bloody, malabsorption and nutritional deficiencies, electrolytes these three bunches. Complication is fistulas, enterocutaneous, enteronetral, enterovaginal, enterovesicular, abscesses, peritonitis, strictures and abrasions, increased risk of small bowel cancer, high recurrence after surgery at the anastomosis site. For ulcerative colitis, we have pathology characteristic limited to colon and rectum, involves mucosa and submucosa only, continuous diffuse inflammation, begins in rectum and extends proximally, rare bowel movement involvement, clinical manifestation, severe diarrhea, often 20 stool per day, bloody mucus-filled stool, it's left lower quadrant abdominal pain. So the other side is right lower quadrant. This is left lower quadrant abdominal pain. Tenesmus, crypt abscess with purulent discharge, complication, toxic megacolon, hemorrhoid, colon cancer, long-standing disease, anemia. Cure possible with colectomy, GI manifestation only. So we have also the intermediate colitis diagnosis used when the Crohn versus UC, ulcerative colitis, cannot be distinguished. Resemble ulcerative colitis more than Crohn's, high risk of both failure after surgery. So the diagnostic evaluation, we have colonoscopy, gold standard, sigmoidoscopy, barium anemia. We have laboratory tests, CBCs, electrolytes, serum albumin, stool studies for pathogen, colonoscopy findings, Crohn's strictures, fistulas, patchy inflammation. For UC, ulcerative colitis, it's friable mucosa ulceration. Intraprofessional management, we have like primary goals. It's rest bowel, control inflammation, treat infection, correct malnutrition, reduce stress, improve quality of life. Team members, primary provider, gastroenterologist, dietitian, nurse, mental health support, wound ostomy nurse. For medical management, fluid and electrolyte management, we have priority in ulcerative colitis, monitor potassium and magnesium, encourage rest to decrease bowel mobility. Pharmacological therapy, it's aminosalicylates, antibiotics, corticosteroids, immunomodulators, biologic agents, antidiarrheals. Nutritional management, we have risk for malnutrition causes, absorption, decrease intake, intestinal losses. Interventions is bowel rest, TPN when indicated, monthly B12 injection for Crohn's, monitor albumin, avoid trigger foods like milk, gluten, caffeine, alcohol, nut seeds, pork, dietitian referral, of course, uh, referral is essential. For complementary and alternative medicine, CAM, used by 30 to 50% of patients includes probiotics, turmeric, curcumin, fish oil, marijuana, herbal supplements, non-FDA regulated, evidence inconsistent. Psychosocial management. Chronic illness, when it's decreased quality of life, stress-related exacerbations, issues is social isolation, body image disturbance, depression and anxiety, special concerns in young adults, self-esteem, sexuality, independence, ongoing mental health screening is required. For surgical, we have for Crohn's disease indication it's obstruction, abscess, fistulas, perforation, cancer, surgery not curative, high recurrence rate. For ulcerative colitis, we have curative procedures, IPAA, proctocolectomy, permanent ileostomy, improve quality of life when medical therapy fails. We have complications, gastrointestinal, fistulas, abscesses, strictures, obstruction, perforation, toxic megacolon. We have nutrition, malnutrition, vitamin deficiencies, anemia. For extraintestinal, it's joint disease, osteoporosis, kidney stones, skin, and eye disorders. Now we go for the nursing management. For nursing management, we start with assessment, right? Intake and output. Usually I say in the nose, so it's intake output. Daily weight, stool frequency and characteristics, vital signs, electrolytes, psychosocial status. Nursing diagnostics, it's for deficient fluid volume, diarrhea, imbalance, nutrition, ineffective coping. Nursing intervention, we have encourage small frequent meals, provide skincare, promote rest, manage pain cautiously, coordinate interprofessional care. Patient teaching here, nutrition and hydration, medication adherence, avoid trigger foods, important to follow up, and colonoscopy. Evaluation and of outcomes, stable virals, balanced electrolytes, adequate nutrition, improve quality of life, reduce exacerbation. So as you see, it's a quite long, this inflammatory bowel disease, because it has Crohn disease and ulcerative colitis. So as you see, the overview, the epidemiology, pathophysiology, clinical manifestation, diagnostics, management, medical complication, nursing management. So now we are going to go to the next one. Since we finished about inflammatory bowel disease with Crohn's disease versus ulcerative colitis, I hope this picture will help you to see Crohn's disease versus ulcerative colitis. I think this make it easier to picture those diseases. Irritable bowel syndrome or IBS, we have few categories. So common symptoms, abdominal pain and altered bowel habits. Irritable bowel syndrome, IBS, we have epidemiology, a functional disorder of the intestine with no known cure, also called spastic colon, nervous digestion, or spastic colitis. Prevalence it affects about 10 to 15 of the population, with females being affected twice as often as males. Associated condition with fibromyalgia, chronic fatigue syndrome, depression and anxiety. Onset most often diagnosed between age of 30 to 50. The pathophysiology, we have subtypes, categories, IBS-C, constipation, dominant IBS-D, diarrhea, dominant IBS-M, which is mixed, alternating constipation and diarrhea, and IBS unclassified. Possible causes, it's under investigation. Gastrointestinal mobility, abnormal muscle contraction, either too slow, IBS-C, or too fast, IBS-SD. Visceral hypersensitivity, increased sensation and sensitivity to intestinal activity. Intestinal inflammatory, increased numbers of lymphocytes and mast cells. Post-infectious symptoms following a long-lasting cause of gastroenteritis. Dietary factors, food sensitivity, carbohydrate malabsorption, like food MAPS, or gluten sensitivity. Genetics, a possible genetic component in some patients. Psychosocial dysfunction, role of anxiety, depression, and stress. Clinical manifestation, we have key symptoms: abdominal pain, alternate bowel habits, diarrhea, constipation, or both, and flatus, gas. Pain often in the left lower quadrant, increases after eating and is relieved by bowel movement, can be worsened by emotional stress. Other symptoms: abdominal distension, weight loss, anorexia, and sense of incomplete evacuation. Specific to IBS-D, may have mucus in the stool, but blood is not typical present. Diagnosis. No single definitive test. Diagnosis is made by ruling out other conditions with tests like colonoscopy, CT scan, or blood test. The ROM-IV or Manning criteria are then used to confirm the diagnostics based on symptoms. Treatment focus symptoms. Treatment focus symptoms based and highly individualized Medication, a wide range of medication are used, including anticholinergics, antispasmodics, antidiarrheals, mu opioid receptor agonists, and various antidepressants like SRS and TCAs. Dietary modifications. Patients are encouraged to keep a food diary to identify triggers. A low FODMAP diet may improve symptoms. Complementary therapies, cognitive behavioral therapy, relaxation, stress management, acupuncture, hypnosis, and probiotics. Herbal remedies, peppermint, fennel, chamomile, and ginger may help with symptoms but should be used with caution. Complication. We have physical fluid volume deficit and hypokalemia from frequent diarrhea. Nutrient deficiencies from avoiding certain foods. Psychosocial, social isolation, anxiety, and depression. For other, it is crucial to rule out other organic diseases that may have overlapping symptoms. For nursing management, we have the assessment. It's assess the vital signs for pain or hydration. Monitor intake output for serum electrolytes for fluid imbalance. Thoroughly assess pain, bowel patterns, and weight. Conduct a psychosocial assessment to identify potential triggers like stress. Nursing diagnostics. We have chronic pain, ineffective coping, ineffective health maintenance. Nursing intervention. We have action, administer IV fluids if needed, establish a trusting relationship with the patient, help the patient avoid trigger foods, and establish a regular bowel routine. Teaching, explain how identify and avoid trigger foods like caffeine, alcohol, specific carbohydrates. Teach to the importance of keeping a diary of diet and stress. Encourage regular meals, adequate fluids intake, exercise, and good sleep habits. Educate on smoking cessation. Evaluating care outcome. Expected outcome include stable vitals and weight, a decrease in symptoms, and the patient ability to adhere to nutrition and activity recommendations. A key outcome is establishing a trusting relationship, as many patients with IBS feel their symptoms are dismissed. So this is all about irritable bowel syndrome with epidemiology, pathophysiology, clinical manifestation, diagnostics, medical management, complication, and nursing management here. Celiac disease, it's the gluten auto attack. So gluten is the trigger, lifelong gluten-free. Screening, it's the key. Celiac disease, epidemiology. It's a genetic autoimmune disorders that damage the small intestine due to a reaction to gluten, a protein found in wheat, barley, and rye. Prevalence affects approximately 1 in 141 Americans, and many remaining undiagnosed. Demographics more common in white population, especially females of European descent, has familial tendencies. Associated condition more common in people with Down's syndrome, Turner syndrome, and type 1 diabetics. Pathophysiology: immune reaction. When gluten is indigested, it triggers an immune response that attacks the small intestine, causing inflammation and damage the intestinal villi. Consequences: the damaged villi lead to malabsorption and malnutrition because the small intestine can no longer properly absorb nutrients. Refractory celiac disease, a rare form where symptoms and malabsorption persist despite a strict gluten-free diet. Untreated complications can lead to another autoimmune disorders like type 1 diabetics or autoimmune thyroiditis. Clinical manifestation: gastrointestinal symptoms for adults is diarrhea, foul smelling like colored 40. Steatorrhea, faulty stools, flatulence, weight loss and fatigue. In severe cases, abdominal pain and bleeding may occur. Atypical symptoms: some patients have minor GI complaints but present with other issues like anemia, dental enamel. Oh my goodness. Defects, osteoporosis, arthritis, or neurological symptoms. Diagnosis difficulty: its symptoms are similar to other diseases like IBS, making diagnosis challenging. We have here for interprofessional management, the diagnosis, the gold standard is endoscopy with a small bowel biopsy. We have the serological test, blood test for antibodies, specifically the anti-tissue transglutaminase antibodies or anti-TG IgA are most sensitive. Genetic tests are also used. For treatment, we have core principle: lifelong strict adherence to a gluten-free diet. Even small amounts of gluten can cause intestinal damage. Key elements: celiac acronyms. Consult a dietitian, educate the patient, lifelong diet adherence, identify and treat malabsorption, access support groups, and continue interdisciplinary management. Medication: it's that patient must check with their provider or pharmacist about medication that may contain gluten. Foods to avoid: all foods containing wheat, rye, and barley, beer, ales, larges, and malt vinegars. Safe foods: rice, corn, buckwheat, quinoa, potatoes, soybean flour, and tapioca flour. We have complications. Most common: malnutrition and malabsorption leading to anemia, osteopenia, and osteoporosis. Long term, We have for persistent inflammation can lead to another autoimmune disorders. Rare refractory celiac disease require TPN. Nursing management. We have the assessment, vital signs, monitor for signs of hypovolemia, decreased blood pressure, tachycardia due to diarrhea. Labs check serum electrolytes for potassium and calcium loss, and CBC for anemia. Stool observe for watery, frothy, light colored, full smelling stools. Knowledge assess the patient understanding of a gluten-free diet. Nursing diagnosing, we have like imbalanced nutrition, knowledge deficit, risk for dysfunctional gastric mobility. Nursing intervention action, refer to a dietitian and support groups. Develop a trusting relationship. Encourage patient to advocate for gluten-free option when dining out. Teaching emphasize lifelong adherence to the gluten-free diet, proper food label reading, consistent follow-up, and using dedicated cookware, utensils, dishwasher use to avoid cross-contamination. Provide resources for gluten-free living. Evaluating care outcomes, successful management is shown by stable weight, normal bowel movements, and normal serum lab values, especially for anti-TTG levels. The patient must understand the long-term effects of non-compliance to maintain a lifelong committed to the diet. So this we cover for the celiac disease, epidemiology, pathophysiology, clinical manifestation, diagnostic, management, complication, nursing. And now we're actually in the half of the chapter. So half more to go. Stay awake. Diverticulitis, inflamed pouches in the colon. Diverticulitis, epidemiology. A diverticulum is a small pouch-like protrusion in the gastrointestinal tract. Diverticulitis is the inflammation of infection of those pouches. Prevalence more common in Western industrialized societies and increases with age. Found in 30% to 50% of adults over age of 60. Affected population, younger men are more affected than women, but this reverse in all the age groups. Risk factors: a low fiber diet, obesity, lack of physical activity, smoking, and certain medication like NSAIDs, opioids. Note that the long-held belief that seeds, nuts, and corn should be avoided is unproven. But to be safe. So the pathophysiology, diverticulosis versus diverticulitis. We have, it's the presence of the pouches without inflammation. Diverticulitis is when those pouches become inflamed or infected. Mechanism: it's a low fiber diet, leads to constipation and straining. Those increases intraluminal pressure, causing the formation of out pouches diverticula. A weak points in the colon wall. Then inflammation, infection, food and bacteria can become trapped in the diverticulum, leading to a decreased blood supplies and the formation of fecalith. The causes inflammation or infection. A location most often occurs in the sigmoid colon, which has the smallest diameters and is more susceptible to increased pressure by dog snores. Com Complication chronic diverticulitis can lead to scarring and narrowing of the bowel, which may cause an intestinal obstruction. We have the next, it's clinical manifestation. I need to press here. Its common symptoms of abdominal pain, usually in the left lower quadrant, fever, leukocytosis, and palpable mass. Other symptoms increase flatus, abdominal bloating, and alternating diarrhea or constipation. Stools may contain mucus and blood, a typical presentation in older adults. They may be a febrile, no fever, with a normal white blood cells count. The first signs of infection can be a change in mental status, like confusion, falling. Signs of complications, it's generalized abdominal pain with rebound tenderness suggests a ruptured diverticulum and the onset of peritonitis. Interprofessional management with diagnostics. We have initial tests include flat plate abdominal X-rays. The diagnostics is confirmed with a CT scan. Avoid the barium enema, as it can increase the risk of rupture diverticulum. So this avoid barium enema, keep in mind, might be in quiz or exams because it says avoid here. Then we have the next treatment. We have uncomplicated, which is managed on outpatient basis with broad spectrum antibiotics and a clear liquid diet that is advanced as tolerated. Complicated, hospital admission is required for severe pain, fever, like more than 100.5 Fahrenheit or 39 degrees Celsius. Significant leukocytosis or microperforation. Treatment involves like IV fluids, bowel rest, and PO, and NG tube for decompression and parenteral antibiotics. Surgical management. I forgot to open for you guys this. So surgical management when is it needed? When medical management fails or for complication like perforations, abscess, obstruction, or fistulas. Procedure, surgical removal of the diseased portion of the colon, which may require a temporary colostomy. Complication is the perforation, abscess, and fistula formation, bowel obstruction, bleeding. For nursing management, we have the assessment, Vital signs, of course, for everything. Monitor for fever and tachycardia, which indicate inflammation or infection. Pain, assess for pain location. Left lower quadrant is typical. Bowel pattern. Note that changes in bowel habits like constipation or diarrhea. Mental status, of course, crucial to monitor in older adults for signs of infection. Labs monitor white blood cells count for infection and serum potassium level, especially if the patient is on NG suction. Nursing diagnosed problem list is acute pain related to inflammation, knowledge deficit regarding diet, hypokalemia due to NG suction or diarrhea. Nursing intervention, we have here action, it's administer IV fluids per MD orders antibiotics and provide care for NG tube if present. Teaching diet, teach the patient to increase fiber from raw fruits to vegetables after the acute phase of inflammatory has resolved. Then activity, advice against straining, bending, and lifting, as those increase intra-abdominal pressure. Weight, encourage weight reduction or as obesity is a risk factor. Medication stress the importance of completing the full course of antibiotics. Evaluating care outcome, we have the patient should be free of abdominal pain and fever before discharge. The long-term goal is to decrease the risk of reoccurrence by helping the patient maintain a high fiber diet. So that we cover for diverticulitis with epidemiology, pathophysiology, clinical manifestation, diagnosis, medical management. We have the complications and nursing management. So that's it for diverticulitis. Appendicitis, the Appendix alarm, appendicitis emergency requires surgery. The appendicitis, we have the epidemiology, acute inflammation of the vermiform appendix, affected population, more common in males and in the 10 to 19 years old group. Older adults, when it occurs in older adults, it is often more serious, with a high risk of rupture and mortality. Risk factors, no specific risk factors or preventive measures are known. Pathophysiology, the appendix, a small hollow appendage of the cecum with no known function. Primary cause, the most common cause, is an obstruction of the appendix opening by fecalith or other foreign body. We have the progression blockage, causes fluid secretion leading to venous engorgement and increased pressure. Bacterial invasion occur, potentially forming an abscess. Gangrene can develop in 24 to 36 hours. Then perforation can occur in as little as 24 hours, but the risk increases significantly after 48 hours. It can lead to peritonitis and it's life-threatening. Clinical manifestation. Initial symptoms begins when cramping, periumbilical abdominal pain, often with anorexia, nausea, and vomiting. Classic pain shift and inflammation progresses. The pain shifts to the right lower quadrant and become more severe and steady at McBurney's point. Diagnostic signs. Rebound tenderness, increased pain when pressure is released from McBurney point. Rough sneak sign, palpation of the left lower quadrant causes pain in the right lower quadrant. Lab findings, white blood cell count is usually moderately elevated, 10,000 to 18,000 millimeters cubes. A count greater than 20,000 millimeters cubes may indicate a perforated appendix. Perforation, septics. Signs of ruptured appendix include elevated temperature, tachycardia, and decreased blood pressure. Interprofessional management. We have the medical primary based on clinical presentation and physical assessment. A CT scan is the most common and reliable diagnostic test. Other tests include CBC and serum electrolytes. Medical management, some uncomplicated cases may be treated within 7 to 10 days course of antibiotic with close follow-up. However, most cases will still proceed to a surgery. Surgical management. We have appendectomy, surgical removal of the appendix is the definitive treatment. Laparoscopy is used for uncomplicated cases, small incision. Laparotomy, it's a larger incision. It's performed if rupture or peritonitis is suspected. Important. Laxative and enemas should be avoided to prevent increased intra-abdominal pressure and perforation. Complication. We have perforation, the most significant risk, peritonitis, contamination of the peritoneal cavity with intestinal matter following rupture. Sepsis, a systemic response to infection that can be life-threatening. Nursing management. We have the assessment, vital signs, monitor for fever and tachycardia, pain, assess pain location and character. A sudden change in pain may indicate rupture. Abdominal signs, check for the rebound tenderness and Singh sign. Lab, monitor white blood cell count for elevation and the left shift. Intake output, monitor for fluid loss and vomiting and fever. Nursing diagnosis, the problem list, acute pain, risk for deficit fluid volume, risk for infection, knowledge deficit regarding pre- and post-operative care. Nursing intervention, preoperative maintain NPO status, administer IV fluids, comfort, apply ice to the right lower quadrant, never heat. Hold pain medication until a diagnosis is made to avoid masking symptoms. Positioning, place the patient in a semi-forward position or side-lying with knee flex to reduce abdominal muscle strain. Post-operative, advanced diet as tolerated. Encourage early ambulation and deep breathing exercise. Intervention, post-operative care, educate on turning, coughing, and deep breathing to prevent respiratory complication. Antibiotics, emphasize the importance of completing the full course of antibiotic, especially if the appendix ruptured. Wound care, if the incision is left open due to a rupture, teach the patient or family how to perform dressing changes and include a home health referral in the discharge plan. So here we have the outcome: pain control, infection prevention, and fluid balance. This was the appendicitis with epidemiology, pathophysiology, clinical manifestation, diagnostic, management, complications, and nursing intervention. And now we're gonna go to the next. Colorectal cancer. We have colorectal cancer as epidemiology and risk factor, everything, but also we have post-operative colorectal cancer nursing management. This section is quite a little bit long, so stay tuned, don't sleep. We have epidemiology. The third most common form of cancer and the second leading cause of death in the United States. In 2022, there were an estimated 108 new cases. So 106,108 new cases of colon cancer and 44,850 new cases of rectal cancer, with a combined death toll of 52,580. Demographic, the overall lifetime risk is about 4.3% of men and 4% of women. The incidence is decreasing in older adults, but increasing in younger adults. Black individuals have the highest incidence and mortality. Risk factors, lifestyle, high fat diets, consumption of red processed meat, physical inactivity, obesity, cigarette use, and alcohol intake. Medical history, personal family history of colorectal cancer, history of adenomatous polyps, inflammatory bowel disease for 10 plus years, and type 2 diabetics, 38% increased risk for that. So protective factors, diet high in fruits and vegetables, regular physical activity, and regular use of aspirin or other NSAIDs. Pathophysiology. Tumor type, most colorectal cancer are adenocarcinomas, which originate in the glandular cells of the intestine. Metastatic cancer can spread by direct extension to adjacent organs through the lymphatic system or via the bloodstream. Common sites of metastasis: the liver is the most common site, but it can also spread to the lungs, brain, bones, and adrenal glands. Genetic condition: FAP and HNPCC are autosomal dominant disorders that significantly increase the lifetime risk of developing colorectal cancer. Symptom clinical manifestation: we have early stages. Symptoms are often vague and may be ignored. Unexplained weight loss and fatigue may be the first signs. General symptoms: change in bowel habits, blood in stools, abdominal pain, distension, a feeling of incomplete evacuation, and anemia. Symptoms by locations: on ascending colon, vague abdominal pain, cramping, change in bowel habits, anemia, and fatigue. Transverse colon, pain, signs of obstruction, change in bowel habits, anemia, and fatigue. Descending colon, pain, change in bowel habits, bright red blood in the stool, and signs of obstruction. Rectum, blood in the stool, changes in bowel habits, and rectal discomfort. For medical diagnosis, screening colonoscopy is the gold standard for screening, allowing for biopsies and polyp removal. Other methods include fecal occult blood test, sigmoidoscopy, virtual colonoscopy, and fecal DNA testing. Screening recommendation: average risk. Ages: between 45 and 75. Begin screening with a stool-based test annually, or a visual exam like colonoscopy every 10 years. Ages 75 to 85 years old. Decision is made based on patient's health and screening history. Ages above 85, routine screening is not recommended. Other diagnostic studies: serum, CEA, CBC, CT, MRI, and abdominal X-rays. Treatment: chemotherapy used to scroll a little bit down. So chemotherapy used to improve survival, especially for patients with stage 2 or stage 3 disease. Common side effects include diarrhea, mucositis, and peripheral neuropathies. Radiation therapy used to reduce tumor size before surgery, provide local control, or as palliative care for advanced disease. It is particularly effective for rectal cancer. Surgical management: the goal is to remove the tumor and a portion of the healthy bowel with adequate margins. Procedure is colectomy, excision of part or all of the colon. Hemicolectomy, excision of half or less of the colon. Abdominoperineal resection, removal of the rectum, and a portion of a colon requiring a permanent ileostomy. Complications. We have treatment-related fatigue, anemia, and increased risk of infection from chemotherapy, diarrhea, blood in stool, and weight loss from radiation. Surgical, blood loss, anastomotic leaks, infection, and incisional dehiscence. Cancer progression, metastasis to other organ is a significant complication, especially in advanced stages. Nursing management. We have preoperative patient assessment, vital signs, serum electrolytes, CBC, and the patient's knowledge and emotional state. Intervention, administer bowel prep, Goliteli. Establish a therapeutic relationship and ensure surgical consent is signed. Teaching, provide preoperative teaching on ostomy care with WOCN consultation if possible, and explain postoperative pain management. For post operative patient, so again, assessment, vital signs, level of consciousness, pain level, bowel sound, CBC, and fluid balance, intake output. Stomach care, if applicable, assess the stomach health, should be reddish, pink, and moist, and monitor the type and consistency of ostomy drainage. Intervention, monitor for complications like infection and bleeding, provide comfort measure and pain management. Teaching, educate on wound care if the incision is left open, and emphasize the importance of discharge follow-up. For this section, also it's quite long in the book, the postoperative colorectal cancer nursing management. So this section of the text outlines the essential nursing management for the patient following colorectal cancer surgery. The focus is on assessment, intervention, and teaching to prevent complication and promote recovery. So, assessment, vital signs, monitor for a mild temperature elevation in the first 48 hours due to inflammation and marked elevation, possible atelectasis. Tachycardia and decreased blood pressure may indicate fluid volume deficit. Labs, assess CBC for mild anemia and elevate white blood cells count, normal inflammatory response versus infection. Monitor hemoglobin and hematocrit to check for bleeding and nutritional deficits. Pain, postoperative pain is expected and adequate management is crucial for patient recovery and to prevent complication. Bowel function, expect severely diminished or absent bowel sounds for 1 to 3 days. Monitor for nausea, vomiting, and patency of any NG tube used for decompression. compression. Fluid status, monitor intake and output to assess for fluid retention and dehydration. Urine output should be at least 30 ml per hour. Surgical site, stoma, if applicable. The stoma should be reddish pink and moist. Report any discoloration as this could indicate necrosis. Drains, assess the amount, color, and odor of drainage from any surgical drains. Penrose, Jackson, Pratt. Incisions, dressing, check for excessive drainage, which could signal bleeding. I had to stop and now I'm back. Mental status, assess for level of consciousness and orientation as changes can be first sign of complication. Nursing diagnostic, the problem list, acute pain, risk for infection, risk for imbalanced fluid volume, knowledge deficit, disturbed body image specifically with ostomy. Nursing intervention, administer IV fluids to maintain fluid balance, maintain NPO status until bowel function returns, then advance diet as tolerated. Provide care for any NG tube to ensure patency and provide decompression. Implement effective pain management strategies, the PCA epidural, to enable patient participation in recovery activities. Manage surgical drains and monitor output. Encourage turning, coughing, deep breathing, and incentive spirometry to prevent atelectasis. Promote early ambulation to prevent VTE, which is the venous thromboembolism. Provide perineal care for patients with an abdominoperineal resection, as this is a common source of significant pain and risk for abscess formation. Teaching reinforce the importance of methods to prevent postoperative complication. Assist with VOCN, which is the wound ostomy and continence nurse, with ongoing teaching about stomach care and management. Provide referral to social workers, home health agency, and ostomy support group to ensure continuity of care. Evaluation of care or outcome. Successful outcome are indicated by stable vital signs, normal hemoglobin, hematocrit, and white blood cells counts. A patent stoma with adequate perfusion and absence of infection. So that's it for colorectal cancer, and we talked about epidemiology, pathophysiology, clinical manifestation, diagnosis, treatment, complications, nursing management, and that's it for this. Abdominal trauma with blunt trauma and penetrating trauma. We are in abdominal trauma, epidemiology. For blunt trauma, no penetrating injury. Most cause it's motor vehicle crashes, which is like about 75%. Most commonly injured organ, spleen and liver. Penetrating injury, it's stabbing or gunshot. Stab wounds, most prevalent than gunshot wounds. It's like about 3 times. Lower morbidity and mortality. Most commonly injured organ, liver. The gun wounds associated with about 90% of mortalities from penetrating injuries. For pathophysiology, we have for blunt trauma, causes motor vehicle accident, falls, assaults, contact sports. Mechanism, concussive and compression forces like tear, hematomas, deceleration forces like organ rupture, results in bleeding and organ damage. For penetrating trauma, causes is gunshot wounds, stabbing wounds. Mechanism, foreign object penetrates the abdominal cavity, results in profuse bleeding, hemorrhagic shock, peritonitis if follow organ are damaged. Clinical manifestation. We have initial assessment, airway, breathing, circulation, the ABC assessment, signs of hemorrhage, shock, and peritonitis. Symptoms vary by organ injured. Several injuries, bruising, abrasion, laceration, discoloration, asymmetry. Specific sign is coolant signs, ecchymosis around the umbilicus, intra-abdominal hemorrhage, Turner sign, ecchymosis on the flap area, retroperitoneal hemorrhage. Absence of bowel sounds, suspect peritonitis, bruits over abdomen, suspect renal artery or aortic damage, often associated with other injuries like bone fracture, head injuries. Diagnosis. We have medical management, laboratory test, baseline, serum chemistry, CBC, urinalysis, type and cross-match for blood imaging, X-ray, CT scan, MRI, if patient is stable. Diagnostic procedure, diagnostic peritoneal lavage like DPL, detects intra-abdominal bleeding, focus abdominal sonography for trauma, fast, ultrasound scan for free fluid. For treatment, we have large bore IV lines for fluid resuscitation, nasogastric, the NG tube for gastric decompression, indwelling urinary catheter for hematuria and output monitoring. Surgical management, it's exploratory laparotomy, surgical repair of bowel perforation or laceration, antibiotics to prevent peritonitis. Complication, we have hemorrhagic shock, peritonitis leading to septic shock, ischemic bowel, paralytic ileus, adult respiratory distress syndrome, the ARDS, disseminated intravascular which is the DIC. Nursing management. So here it's based on advanced trauma life support. It's the ATLS. The ABCDE protocol, which is airway, breathing, circulation, disability exposure. Assessment and analysis. It's like prioritize airway management, vigilant observation for rapid changes in vital signs. Clinical manifestations are tachycardia, tachypnea, pain, bruising. Nursing diagnostic risk for ineffective airway clearance, risk for deficit fluid volume, acute pain. Then intervention, airway, vital signs, level of consciousness, the Glasgow Coma Scale, signs of hypovolemic shock, CBC, urinalysis, serum electrolytes, bowel sounds, area of injury. Administer oxygen and IV fluids, control bleeding, do not remove protruding objects, administer antibiotic, consult for type and cross match, teaching, explain procedure, keep family informed, wound care, nutrition, clinical manifestation of infection. For the outcome, we have psychosocial stability, stable vitals labs, no signs of infection, adequate pain management, patient independence in wound care. And for lastly, we have the hypovolemic shock signs, which are restless, anxiety, confusion, cool, clammy skin, weakness, pale color, tachypnea, tachycardia, hypotension. So that is all about abdominal trauma. And we talked about epidemiology, which is the two-part, pathophysiology, clinical manifestation, diagnostic, treatment, complication, nursing management, hypovolemic shock. So that's it for abdominal trauma. For exam purposes, how to distinguish between deadly and common bowel issues. We have in three categories, and number one, the golden rule of GI nursing, safety first. The big question when a patient has stomach pain, is it something simple like gas, constipation, or life-threatening like a rupture or blockage? NCLEX tip, always prioritize acute, sudden, severe over chronic, long-term issues. Then the two, we have the blockages, constipation or obstruction based on bowel intestinal obstruction, the common, less urgent, partial obstruction, the patient might still pass some gas or have small bowel movements. Assessment, you might hear high-pitched bowel sounds, the borgorhythmia, that is the key term for high-pitched bowel sounds, borgorhythmia. As the gut tries to push past the block. The deadly, the emergency, complex obstruction, no gas and no stool are passing, so it's obstipation. Red flag symptoms, severe continuous pain, rigid board-like abdomen. This suggests perforation bleeding. Vomiting can smell like feces with small bowel obstruction. Action, keep NPO, nothing by mouth immediately. Number 3, the bulge, annoying or strangulated. Based on hernias, the common we have the reducible hernia. The bulge appears when lifting or coughing, but goes back in when the patient lies down. It is uncomfortable but not an emergency. The deadly emergency, the strangulated hernia, the blood supply is cut off. So the red flag symptoms, severe pain, fever, nausea, and the bulge cannot be pushed back in. Action, this requires immediate surgery to prevent tissue death, which is the gangrene. We just finished the entire chapter. I hope you like this way I did it today, and I hope also you learned something from each of these 10 disorders of intestinal disorders. That's it for today. Thank you for being to the end, and see you in NCLEX practice, the part 3. So stay tuned for that. Thank you. Bye for now.
We finally made it!
Thank you again for your time and trust. I'm Melania, and from my heart to yours. Until next time, stay zen, stay grounded. Namaste. Bye for now.